Okay, I think I will start. Okay, can you see my screen?
Yes, doctor.
Okay. Right. So today we're going to talk about the class 2 malocclusion. So we are going to talk about the class 2 division 1, then followed by the class 2 division 2. So what's the learning outcome today? So at the end of lecture, you should be able to explain the classifications and the ethology of class 2 division 1, and then followed by the class 2 division 2 malocclusion. Then you should be able to discuss the criteria for the patient assessment and dependence of treatment plannings and the class 2 division 1 again followed by class 2 division 2. Then you should be able to explain the clinical features of the class 2 division 1, then followed by class 2 division 2 again. Then explain the treatment planning for the class 2 division 1, class 2 division 2 with a special emphasis on the reduction of the overbite or the class 2 division 2. So we all know the class 2 division 2, usually patients have a deep bite or maybe overlapping between the upper and lower teeth a bit more than average. How are we going to open the bite? So I think you have to talk about this later. So what's the content today? So we're going to talk about the class 2 division 1 first, then same, then we're going to talk about class division 2 later, then started by this introduction, then followed by ethology, and what's the occlusive features, then patient assessment, how we're going to assess the patients, then how we're going to plan for the case later. So introductions, the class 2 malocclusions, it just means the upper teeth sticking out a little bit. So usually the patient has been called bunny teeth or goofy teeth. So goofy is just a character from the Disney, and you can see the bottom right, this is goofy. Then patient usually have the aesthetic concern, and they call it social handicap because they're always teased by the colleagues or the friends or the classmate. Then patient, because the upper teeth is sticking out so much, patient usually have a difficulty in achieving the lip seal. I mean the lip is not competent. So when they bring the lower lip against the upper teeth or the upper lips, then they have difficulty because the teeth is sticking out so much. So they usually have this increased risk of trauma. So when the upper teeth is sticking out so much, then whenever you hit something, the wall or something, baseball pack or anything, then there's always a risk that will touch the upper incisor first. So if the force is too high, it might fracture the upper incisor. So if you see this class division 1 patients, then sometimes you see the incisor chip off a little bit, or sometimes they might have the half of the incisor fracture. Then they have a composite fillings or sometimes even a crown if they're involving the pulp. So I think this picture we discussed and we showed you before in the last lecture. So according to this British Standard Institute, then when patients have an increased overjet, more than 4 millimeters, then they consider increased overjet. So what's the class 1? Class 1 just means the lower incisor edge is occurred on the cingulum plateau on the upper incisor, which is a meter 1/3 on the palatal surface. Then compared to class 2 division 1, which is the lower incisor, is occurred behind the cingulum plateau, which is behind, slightly posterior. Then the upper incisor slightly proclined or on average. Then the class 2 division 2 then just means that the lower incisor edge is occurred behind the cingulum plateau, but the upper incisor usually a bit retroclined or they can be upright. Class 3 just means they occur in front of the cingulum plateau. So overbite, the average is about 1/3 to half. Just to remind you again. So according to the British Standard Institute classification, class 2 division 1, it just means the upper incisor procline or average inclinations with increased overjet because the lower incisor is occurred behind the meter depth of the upper incisor. That's why the upper incisor is sticking out a little bit. Class 2 division 2, it just means that they occur behind the cingulum plateau, but the upper incisor usually is retroclined with minimum or no overjet. Sometimes they are so close to each other, they don't even have the overjet. So again, this another doctor, Winter Landon, then further classified the class of division 2 into 3 types. This one is not important. I think the exam may be, if they're asked also, it's going to be in the objective questions. They are not going to be essay questions, but it's good to know. So this Vender Linton, they further classify the class of division 2 into 3 types. So type A is upper incisor and lateral incisor retrocline. It's less severe in the nature. So you look at these 4 incisors, they're slightly retrocline, but they are still aligned with the incisor. So from top or occlusal, you can see there's like a square box. So type B just means the central incisor or retrocline and are overlapped by the lateral incisor. So you see these 2 incisors, they're retrocline, then they overlap with the lateral incisor. It means the 1 and 2, they're overlap. So type C is a more severe one. Then the central and lateral incisor usually retrocline and overlap by the canine. You see these 4 incisors, they're all retrocline, then they're behind this canine. So this is a more severe class 2, division 2. So type A, so look at the type A. So type A just summarized by the picture just now. It's a 4 central incisor and lateral incisor. They're slightly retrocline, but they're still aligned with the canine. Type B just means the central incisor retrocline, but the 2 or lateral incisor, they are slightly aligned, just the central incisor retrocline. Type C, there are 4 incisor retrocline. You see the canine is also buccally excluded. So there are 4 incisors totally retrocline, then they are behind the canine. So type C usually is a more severe one. Again, according to the ankle, which is according to the molar, the classifications. So ankle classified the class 2 malocclusion is the distal relationship of the mandible to maxilla, which is purely based on the molar relationship of the first permanent molar. So they say the mesial buccal cups of the maxillary first molar, mesial buccal cup is occlude mesially or mesial buccal groove to the mesial buccal groove surface of the mandible first molar. So mesial buccal groove of the lower molar, if this upper mesial buccal cup is occlude anterior or mesially, then consider class 2. So we use the mesial buccal groove as a guide. So mesial buccal cup should occlude on the mesial buccal groove. This consider class 1. Slightly forward, consider class 2. Then slightly backward, consider class 3. So again, I think we discussed in the last lecture, when we say class 2, then mostly we refer to incisor. Of course, you can further detail telling the molar relationship as well, the canine also. So what's the ethology for class 2 malocclusion? So the last lecture also we touched about this ethology. Can they further divided into these skeletal, dental, soft tissue, and habit. Same with the class 2 also. So the first one should be skeletal, because the retronetic mandible, it just means the mandible is a bit shorter than the maxilla. So if you cover the upper face, then you see how short the mandible is. Then it can be the prognatic maxilla. It means the maxilla is slightly longer than the mandible, which is on the picture on the right side. So this one is a short mandible. So this one is a long maxilla. Or it can be combination of both. It can be combination of both, which the maxilla is a bit too long, the mandible a bit too short. So they create a gap between the upper and lower jaw. That's called class 2 skeletal. So the first reason is the jaw, because the jaw discrepancy between the upper jaw and lower jaw. That's why they call class 2 skeletal pattern. Then the class 2 skeletal pattern will cause a class 2 malocclusion. So sometimes it can be due to vertical skeletal pattern. It's due to these posterior growth rotations. So you see the mandible and maxilla. If the mandible growing backward or rotated backward, then it's going to create a gap between the upper and lower jaw. So imagine this picture on the right side. If the jaw or the mandible rotated backward, then it becomes slightly class 2, the patient. So backward rotations will cause a class 2 skeletal pattern. So some skeletal class 2, they have a high angle. High angle, it means the maxillomandibular angle is a bit higher than average. So we call this a high angle. So high angle usually is a backward rotation. See on this cap, it's a stiff angle. So this one called it backward rotations. So dental factor, so we talk about skeletal, maybe it's the skeletal upper maxilla too long, lower mandible too short. Then the second reason can be due to dental factor. Usually it's a space discrepancy. It means the crowding. Crowding in the lower arch mainly. It means the upper, they have a well aligned or sometimes spacing. Then the lower is crowded. So even though patient have a skeletal class 1, you still end up with the increased overjet, which is class 2, division 1, most of the time. So this one considered class 2 malocclusion, but it's a dental factor due to dental, which is a crowding on the lower, usually anteriority. Soft tissue. So soft tissue is one of the important ethology for class 2 malocclusion. Then usually it's due to the lower lip trapped behind the upper incisor. So if the lower lip trapped behind the upper incisor, then they're going to porcine the upper incisor, or sometimes patient will become incompetent lips. So we can further classify into two divisions, two groups. Well, first one is a potentially competent lips. Patient can achieve the competent lips if they are slowly or they forcefully bring the lower lip against the upper incisor. That's due to the upper incisor slightly porcine. That's why patient have an incompetent lip. So once they bring the lower lip forward a little bit, then they can achieve the competency of the lips. So the second one is the totally incompetent lips. It's due to skeletal. So because the upper incisor, the maxilla is too long or the mandible is too short, that's why the lip is not able to achieve competence. So this one is due to the skeletal. So dental mostly become potentially competent, then skeletal usually incompetent lips. But if you come to clinic, then when you're doing the clinical examinations, I think you just have to say the patient competent lips or incompetent lip, as simple as that. So if they can bring the lip together when they rest, then consider competent. And if they're unable to do that, then consider incompetent lips. So patient try to achieve anterior oral seal because anterior oral seal is very important for certain pronunciations. So when patients try to achieve the oral seal, then they can do by a few ways. So first one is a circumoral muscle activity of the lip to lip seal. Then it can also do by posturing the mandible forward. Sometimes if the mandible is too short, then it can always bring the mandible forward. By doing that, then the lip can achieve the competency. Then the lower lip is drawn behind the upper incisor. It can be due to the upper incisor is too porcine, then the lower lip trapped behind the upper incisor. Then that's why they have to bring the mandible forward to achieve the lip seal. So it can be due to the tongue thrust between the incisor, then the contact lower lips. That's called the adaptive tongue behavior. So the normal normal tongue posture, it should be behind the upper incisor. So it's behind the upper incisor on the palatal surface. But because this patient trying to achieve the the oral seal, then the tongue thrust can happen. Tongue thrust means the tongue will come between the upper and lower incisor. Then by doing that, they create the anterior open bite. But patient can achieve the tongue seal by pushing the tongue forward. So it can be a combination of all this. So incompetent lips can cause a lot of problem. So habit, it can be due to the severity of the upper incisor, malocclusion. It depends on the frequency, intensity, or duration of habit. So class 2 malocclusion usually due to the tongue sucking habit. So imagine if the patient put the tongue behind the upper incisor, they're going to procline the upper incisor. At the same time, they're going to push or rectocline the lower incisor. So upper incisor will push forward, then lower incisor will push backward. And the severity of this malocclusion depends on the frequency, how often they suck the tongue, and the intensity, how hard they suck it, and how long they suck it. So whenever you encounter these patients, they're having tongue sucking habit, then they always ask these three questions. So this one is frequently asked in the exam. So how frequent they suck the tongue, then how hard intensity they suck the tongue, and how long they suck the tongue. So this one is very important. So in the persistent digit sucking habit cause a proclination of the upper incisor, like in this picture, it's summarized. When you put the tongue behind the upper teeth, then they're going to always push the upper teeth forward, which causes proclination of the upper incisor. Then if it's a severe one, they will cause an anterior open bite. So it depends, they put in the left side or right side or in the middle. If they put in the left side, then it causes the lateral open bite. Then go in the middle, then it causes the anterior open bite. Then again, also they cause this recognition of the lower incisor. You push upper incisor forward, then push the lower incisor backward. Then they also have this incomplete overbite or localized anterior open bite. Then not only that, they also have this narrowing of the upper arch due to the lower position of the tongue and negative pressure generated. So whenever they suck the tongue or any fingers, then they're using this buccinator muscle. See, the buccinator muscle is on the left and right. So this buccinator muscle is going to compress or constrict the upper arch. So usually when they have tongue sucking habit, they can have the narrowing of the upper arch due to the buccinator muscle created pressure. So patient have the procline upper incisor, narrow upper arch, anterior open bite, and sometimes proclinations of the upper incisor are resignation of the lower incisor. So when they ask what's the tongue sucking habit features, then you should be able to write this down. Upper incisor procline, lower incisor retrocline, anterior open bite, and then narrowing of the upper arch. So it can be due to other factor also, which is a natal factor. It means something wrong when deliver the baby. So improper forceps application during delivery can lead to these condylar fractures or damage, thereby causing the internal hemorrhage or bleeding into the joint area. So whenever you have the damage to the joint area condylar, then the joint area may later become ankylosed or fibrous, which leading to underdeveloped of the mandible. So let's say if you injured only one side, then it cause asymmetry of the jaw. Let's say the fracture both sides, then the mandible can be constricted. Sorry, the mandible can be fibrous or ankylosed, then it become underdeveloped, which will have a short lower jaw. So this one can happen, but not very common. The latest technology, I think become less common now. So what's the occlusive features for the class 2 malocclusions? Then usually they have this class 2 ankle or molar relationship, or you have a British BSI, which is an increased overjet, then procline upper incisor or upright incisor in the skeletal discrepancy. You can have this increased overbite, which is a deep bite, or sometimes you can have an anterior open bite. Depends what is the etiology. Then usually, because the upper incisor is procline, then patient have this incompetent lips, habitually apart at rest, causing the drying of the anterior gingiva. So because the lip is not competent, then patient cannot close properly. Then a lot of time it causes dryness to the gingiva. So you look at this patient, a lot of time they have gingivitis due to the dryness from the incompetent lips. So when you assess the patients, then you should do it extraoral and go to the intraoral. So patient age is one of the important factor to be considered. So when the patient is young, there always a potential the further growth expected. Then if favorable, it means the lower jaw will grow longer, which is favorable. So VTO is called visual treatment objective. So what you're trying to do, you ask the patient to posture the lower jaw forward. Then if they maintain this lower jaw forward, then they become a better class 1 features, then consider favorable VTO. And that's why we're trying to achieve. So this is usually what we do with the functional braces or appliance. So vertical skeletal growth and posterior growth rotations consider poor prognosis. So if you have this backward rotation, like in this bottom right, is considered posterior growth rotation. So this one consider poor prognosis. So when the patient have the jaw rotated backward, they become slightly more class 2. If the patient have the jaw rotated forward or anterior growth rotation, this one usually become more class 3. So when you take an X-ray, you notice the patient have backward rotation, or this patient have a posterior growth, then maybe this is considered a poor prognosis patient because they have become more class 2 with time. So lack of growth limit the treatment by orthodontic means. So if the patient is not growing, let's say you and me, we are already considered adult, we are not growing anymore. So the option will be quite limited because you cannot modify the growth anymore. That means whatever you see is already fixed. So you cannot do some growth modification treatment. Then you only can use is orthodontic treatment. Then a lot of time they involve extract the upper premolar, then to bring the upper incisor backward. Or sometimes the more severe case, then you have to go for skeletal or orthodontic surgery. So skeletal pattern, then we have to assess the patients anterior posteriorly, then we have to look at the vertical skeletal discrepancy. And the procedure, like we say, we assess the maxilla or the mandible. It can be maxilla forward or mandible backward, or it can be a combination of both. So vertical skeletal, like we summarize in this picture on the right side, it can be forward growth or backward growth, or backward rotation or forward rotations. So this one will determine the prognosis of the patients. Soft tissue pattern, so we identify the ethology. Sometimes you have to check whether the patient has the thumb sucking habit, and you try the correcting it first. So I think we mentioned in the last lecture, we always try to eliminate all the habit or stop the habit before we start the treatment. Otherwise, whatever you're correcting is not going to be stable. Then the patient will come back. It means a relapse of the malocclusions. So the lip trap with potentially competent lips and correct with the retraction of the upper incisor within the lower lips. So if the lip trap behind the upper incisor due to the proclination of the upper incisor, you can always bring the upper incisor back. Then by doing that, then patient can achieve the lip competency. So increase the vertical skeletal proportions with the incompetent lips. They consider the poor stability following treatment. So imagine this patient have the long face, and it cannot achieve the lip competency. Then this kind of patient, even if you bring the upper incisor backward, because the lower lip cannot cover the upper incisor. So this one may be not stable, even though you bring the upper incisor back, that's due to the lip is not competent. So this kind of patient may be not stable. So whenever you try to correct the class 2 malocclusion, you always try to bring the lower lip against the upper incisor. See if the lower lip rests on top of the upper incisor, that is considered stable correction. So if they cannot achieve the lip competency, it means the lower lip cannot rest on the upper incisor. That's considered not stable result. Because the upper incisor can always come forward again without the lip resting on it. So the ideal position at the end of treatment, the lower lip should rest on the incisor third of the upper incisor. So incisor third, again, is the metric number. It's about 2 to 4 millimeters. So the lower lip should rest on top of the upper incisor, about 1/3. So facial appearance, then we should consider the patient profile for the type of treatment it's going to consider. So let's say patient have the longer maxilla, then maybe we go for the headgear. See the upper maxilla is too long, then you go for the headgear. Then hopefully can bring the upper maxilla back, or if not, we're trying to restrict the growth of the maxilla. So when we have lower mandible, which is too short, retracted mandible, then we try to bring the lower jaw forward, which we use the functional appliance. So if the lower mandible is too short, then maybe you will do functional appliance, trying to bring the lower jaw forward. And if the maxilla is a problem, then we try to use a headgear to bring the maxilla backward. So it depends what is the cause of this class 2 skeletal. So surgical approach, then usually when it comes to severe case, which our patient is not growing anymore, then surgical approach might be more appropriate. So surgical approach is preferred in some cases, such as obtuse nasolabial angle and excessive incisor show. So what I'm trying to say is, let's say the upper nasolabial, it means the angle between the nose and the labial surface of the upper lip is called nasolabial angle. So the normal angle is about 90 to 110. So obtuse, it means it's more than 110. So let's say it's already quite flat. It means the upper jaw or the upper incisor is not proclined. Then the lower jaw is too short. This kind of case may be not suitable for braces only, because whatever you do, you cannot make the upper lips too flat. It must be a certain angle to achieve the aesthetic. So this kind of patient, when it comes to severe case, then maybe we'll go for surgical approach. So the patient profile is one of the criteria influencing the decision of the extractions. So a lot of time, if the lip is sticking out, or protrusion of the upper lip and lower lip, a lot of time we try to take out the teeth, then bring the upper lower incisor back. Then by doing that, we'll flatten the profile quite a bit. So you look at these right pictures, you see the upper lip is protruding. Then we do extraction, bring the upper incisor back. Then because you bring the upper incisor back, the lip also will fall back. So by doing that, you achieve a straighter profile. That's how we change the facial profile. So when upper lip is too protruding, then most of the time we take out teeth and then they retract the upper incisor. By doing that, we can change the facial profile. So treatment planning for Class 2 Division 1 with a mild Class 2 or skeletal 1 skeletal pattern, which is not severe. Like we said before, severe case, then most of the time we deal with surgery. But if they come to mild or maybe moderate, or maybe have a patient have a Class 1 skeletal pattern or mild Class 2, then a removal appliance can be done. Just to do some simple tipping job. So you know the removable, we can do a lot of tipping by doing the labial bow on top. Then we can bring the upper incisor back by doing the simple tipping movement. But when you come to bodily movement, it means you have to move the root back or root talking. Then maybe we have to use a fixed appliance with extractions. So when it comes to moderate case, then a lot of time we can do orthodontic camouflage. It means you take out some good teeth, then changing the incisor angle. By doing that, then you consider orthodontic camouflage. We are not changing the skeletal pattern. We just simply do extraction, then changing the upper incisor angle from procline upper incisor, then maybe you bring it back, it becomes upright. Then that's considered camouflage treatment. So we can correct the overbite. We have to correct the overbite before the overjet. So let's say patient have the deep overbite. You always open up the bite, intrude the upper and lower incisor, or maybe just lower incisor, open up the bite before you can bring the upper incisor back. So if they're locked together, you just keep pushing the upper incisor, you cannot reduce the overjet because upper and lower incisor will come together. They'll come backward together. So when you come to deep bite patients, you always correct the overbite before the overjet. So this happened to a lot of general practitioners out there. When they do the treatment for braces, they always forget these first basics rules, which is correct the overbite before the overjet. So next time, if you start ortho treatment in private or in any way, so you always remember you have to correct the deep bite before the overjet. Don't try to bring the upper incisor back without correcting the deep bite. So by doing that, you're making a big mistake. So overbite always comes before overjet. So overbite correction requires space in the lower arch. So let's say have a deep bite, big careful speed. Then if extraction required in the lower, then it means the upper also have to remove some good teeth. So a lot of time we try to balance the number. So you do 2 extraction on the bottom, then it means you have to do 2 extraction on the top, just to balance the number. Otherwise, the top teeth will end up sticking out too much. So that's called balancing extractions. So Class 2 Division 1 with a well-aligned lower arch, then maybe distalization of the upper buccal segment with headgear if the molar relationship is half unit Class 2 or less. So let's say it's just slightly Class 2, not the severe Class 2, then maybe you can bring it back by using this headgear only, provided they are well aligned, no crowding. So when it comes to severe crowding, quite straightforward, we take out good premolar, then generate the space for the alignment. But let's say it's a well-aligned teeth, then you just want to bring the whole jaw back, then maybe you can consider the headgear instead of extractions. So braces is very simple. If you need a lot of space, then we take out teeth. If you don't need that much of space, maybe you try not to take out teeth. Because whatever we're taking out is considered good and sound too. So you no reason, then you do sacrifice the good teeth. So orthodontic camouflage. So you can do some bodily retraction of the incisor based on the availability of the palatal cortical bone and the patient profile. So you see, you can bring the upper incisor back, provided they have a bone at the back of palatal surface. We call it palatal cortical bone. So you want to bring the teeth back, you must make sure there's a bone behind the teeth. If no bone, you bring the upper incisor backward too much, then we end up the teeth are coming out from the bone. So first thing you have to check whether it's a palatal cortical bone or not. Then also the patient profile. So like we show you just now, the pictures on the bottom right. So let's say the profile is very protruding. So it makes sense to bring the upper incisor back. So by doing that, then the lip also will fall back because the lip is supported by the upper incisor. So if you bring the incisor back, then the lip also will fall back. So if the patient have the protruding skeletal profile, then a lot of time we take out the good teeth and bring the upper incisor back. So you can look at these pictures. You see the upper incisor is so proclaimed, so massive overjet. So we can take out the premolar, then we should generate about 7 millimeters on both sides. Then we can retrocline the upper incisor back and make it upright. So same with this case, you see the upper incisor procline, class 2 division 1. So we want to bring the upper incisor back. So we sacrifice the good premolar, which is number 4. Then by doing that, we can upright the incisor quite a lot. So class 2 division 1, we moderate to severe skeletal 2. So just now we talk about the mild or the moderate, then we can always do simple or removable braces, or sometimes in the more difficult case, then we will do the fixed appliance with or without extractions. But when it comes to severe case, so severe case, you always deal with surgery a lot of time. So early treatment, sometimes severe case, when the patient is still growing, you can do some early treatment. It's a prominent incisor with susceptibility to trauma and aesthetic concern, cause a lot of social or psychological impact, then they warrant the early treatment. So sometimes we look at the kids, they are very shy, not confident due to the upper teeth sticking out. Then maybe we can try to do something early to help them to boost up the confidence. Then not only that, if you bring the upper incisor backward, you also reduce the risk of the trauma of the upper incisor. So this kind of patient, maybe you can try to start early. So the factors to be considered during the early treatment, let's say you want to start early, then you have to consider the following factors. Incompetent lips in growing patients, reduced stability, require prolonged retentions. So patient, if they have incompetent lips, then growing patient, then even though you correct it, then they're not stable. You need to maintain or retain the result then to a certain stage, which is after they are stop growing. So if we start early, you remember the retention phase will be longer. So sometimes you burn out the compliance. So patients, once you corrected the problem, they're not stable. You need something to maintain the result. So space consideration limit the complete reduction of overjet. So when you start early, then you try not to take out the teeth. So you're not taking out the teeth because you're not doing these fixed braces. Then maybe the space available is quite limited. That's how much you can bring the upper incisor back is quite limited. So retraction of the upper incisor before the canine eruption. So we all know the upper canine always the last one to erupt. So if you bring the upper incisor back too much, it might take up the space for the canine eruption. So it might cause the canine and the retroincisor they bang on each other or they touch each other. Then there's always a risk of resorption or diffractions of the root of the canine. So sometimes when they start too early, then we try not to bring the incisor back too much, not against the canine. You have to give some space for the eruption of the canine. So a lot of time when they come to ugly ducking space, then we try not to close it because it will cause impaction of the canine. So further treatment often require impermanent dentition. So even though you treat this overjet early, then maybe later patient is still subject to this fixed braces treatment later. So whatever you do early, maybe it reduces the severity, but it doesn't omit the patient from the fixed appliance treatment. So you try to reduce the overjet, but you have to tell the patient, maybe later you still need the fixed appliance or the fixed braces treatment. So first thing we can do, how we can do it to reduce the overjet when the patient is still young is by doing this functional appliance. So you see the functional appliance, this is called twin block. There's one block on top, then one block on the bottom. So these twin blocks only work if the patient have two, upper and lower. So the theory is when the patient bite together, then they always posture the lower jaw forward. By doing that, these two blocks will lock together and they stress the jaw muscle, which is a masseter muscle. Then the muscle is going to pull the upper teeth backward, then the lower teeth forward by using this block. So this block, if you wear it about 1 year, it can reduce the overjet quite a lot. So you see the upper procline incisor, it becomes slightly upright. Then the lower jaw also will advance forward a little bit. So what's the retention? Retention is until the growth is complete. So let's say if you start maybe very early, you want to start about 9 years old, or sometimes people will start at 8 years old, then you have to retain the patient until the stop complete, which is about 18 years old. So if you start too early, then patient might burn out with the compliance. You have to wear this functional for about 10 years, which is not making sense. So that's the reason you have to balance the risk and benefit before you start any treatment for the patients. But functional is a good choice if you want to start early. So you can see these pictures is wearing the functional. So you can see the lower jaw before is a bit retrognatic or a bit short for the lower jaw. Then upper the functional, after functional braces or functional appliance, you see the face a bit straighter. Lower jaw is having at once forward. Then the upper lip also come back a little bit. So this is called jaw or growth modification treatment using the functional twin block. So surgical correction, usually for adult with the skeletal discrepancy beyond the limit of camouflage. Let's say the lower jaw is too short, way too short, or the upper jaw is too long. It means the gap between the upper teeth and lower teeth is too far. Then maybe it's not suitable, just do braces on it. So maybe surgical correction will be a better option. So usually what the surgeon do is maxillary setback, means bring the maxilla back, and then mandibular advancement or combinations. So if the maxilla is too long, you cut the maxilla and then bring it back. If the mandible is too short, you cut the mandible and then bring it forward. Or you can do both. You can bring the maxilla back, then bring the lower jaw forward. Then by doing this combination, you should be able to correct the skeletal discrepancy. So the gummy smile, due to the increased vertical growth and short upper lip, was with the incisor retraction. So if you're doing extractions, you bring the upper incisor back, then usually they'll worsen your gummy smile because the lip can pull a bit higher. If you retract the upper incisor, then they'll make the gummy smile worse. So gummy smile, if you do the extractions, then you bring the upper incisor back, then they'll make the gummy smile slightly worse than the current situation. So you have to be careful. So sometimes high pull headgear in growing patients, but requires surgery in adult. So if the patient is still growing, they have the maxillary access or gummy smile, you can use the high pull headgear. So the high pull headgear can pull the upper maxilla upward and backward also. So this is only can be done in the growing patients. When it comes to adult patient, then maybe you hit this maxillary impaction surgery, which should left for one surgery. So this table, it just summarizes everything I said just now. For teenagers and adults, what's the difference? The main difference is teenagers still growing, and adult, we are not growing anymore. So teenagers, there's more things you can do compared to adult. So when it comes to mild or moderate case, you can do fixed appliance with extractions, or sometimes the moderate case, you can do the functional appliance, bringing the lower jaw forward, and then followed by the fixed appliance. Means first stage, you use a functional twin block to reduce the overjet. Then after that, you deal with the crowding by doing the fixed braces later. But when it comes to severe case, same thing. Maybe we get a combination of fixed appliance and the jaw surgery. But for adult, because they are not growing anymore, so functional appliance is not an option. So we jump straight to fixed appliance with extractions, or sometimes combination with a fixed appliance and jaw surgery. So adult, then they're not growing, so functional or jaw modification treatment is not there. So they jump straight to the braces. If the worst case, then we go for surgery. Compared to teenagers, because they're still growing, we can do headgear, functional, or more jaw modification treatment. Okay. So we finished with the class 2 division 1 treatment. Now we come to class 2 division 2 treatment. So again, we'll go through ethology, the features. Then first thing, skeletal. Then followed by dental. Then soft tissue. And the last one is habit. So skeletal. Skeletal, we're going to talk about this skeletal. Just now we already talked about this. Then usually due to the short lower jaw, or it can be long upper jaw. But this class division 2, the features is they have the reduced lower facial height. I mean, patient have the short lower face. This is due to the forward growth rotations, then the prominent chin and increased overbite. So imagine this jaw growing forward or rotate forward, then it usually cause a deep bite. So Class 2 Division 2, then usually they have this forward rotation. Class 2 Division 1, a lot of time they have this backward rotation, or sometimes it can be average. So dental factor, the crowding exacerbated by this retrocline upper incisor, causing the lower incisor to be trapped wrinkly. So imagine this upper incisor, they are retrocline, then due to the deep bite, they will bring the lower incisor back as well. So upper and lower incisor, they are trapped lingually. It's not only upper incisor, upper and lower incisor trapped lingually. Then they have to increase crown root angulation of the incisor due to the high lip line contributes to increase inter-incisor angle. So imagine this is a normal incisor angle, which is about 134, 134. So usually when this normal inter-incisor angle, that means the lower incisor is biting on the synchronous plateau of the upper incisor. So when this upper incisor retrocline and lower incisor retrocline, then they have this increase in the incisor angle. It means more than 134. See, it's more than 134 because this incisor is retrocline, upper and lower. So crown root angulation, it just means this one is a crown, this one is a root. But because the lip is very powerful, then during the development, then the lower lip is going to retrocline the upper incisor. Then patient is going to have this increased crown and root angulation. So soft tissue factor, just we talk about skeletal, dental, then we come to the soft tissue factor. Then usually patient have to reduce over facial height, contribute to the high lower lip line, causing the retroclination of the upper incisor. So you see this upper incisor retrocline is due to the powerful lower lip. When the lower lip is very powerful, then it can bring the upper incisor backward or retrocline the upper incisor. But sometimes, because the lip is not high enough, then the lateral incisor escape. So lateral incisor having the short clinical crown length, then they escape the action of the lower lip and apocline and rotated mesiolabially. So the lower lip can cover the top incisor, central incisor, but because the lateral incisor is quite short, then the lower lip cannot cover the upper lateral incisor. Besides these two lateral incisor escape, only the central incisor retrocline. These two lateral incisor escape. So they usually slightly apocline and they're rotated mesiolabially. So sometimes we have this bimaxillary retroclination. It's caused by the active muscular lips, irrespective of the skeletal pattern. So let's say you have a very powerful lip, then this lip is going to bring the upper and lower incisor back. Then it's causing this bimaxillary retroclinations. So the last lecture, we talked about this bimax protrusion. It's due to the lip is very flaccid, which is usually by this Afro-Caribbean patient. But when you have opposite, which is a very strong lip, then upper and lower incisor is going to cause bimax retroclinations. So bimax proclination is due to the very flaccid or very weak lips, but the bimax reclination is caused by the very powerful lips. So what's the occlusive features of this Class 2 Division 2? So Class 2 Division 2 usually not due to habit. So just now we cover the skeletal, dental, and the soft tissue. But last thing, the habit is not happening in this Class 2 Division 2. Class 2 Division 1, yes, because you have thumb sucking habit, then maybe you can push the upper incisor forward, then lower incisor backward. By doing that, you're going to have Class 2 Division 1. But Class 2 Division 2 usually not due to habit. So what's the occlusive features for this Class 2 Division 2? Again, this patient should have a Class 2 angle molar relationship. Just mean that the mesial buccal cups is occlude in front of the mesial buccal groove or the lower molar. Then they usually have the retrocline upper central incisor due to the strong and powerful lips or muscular lips. Then it's the retrocline the upper incisor. Then procline and mesiolabial rotated upper lateral incisor. Like we said before, due to the upper incisor, lateral incisor a bit shorter. So the lower lip cannot cover the upper lateral incisor. That's why they escape. So it can be procline and rotated mesiolabially. Then deep and complete overbite. So this one patient, because of retrogressions of the upper and lower incisor, then they have a deep overbite, and it can due to the forward rotations or forward growth of the mandible, then causing the deep complete overbite. So sometimes the bite is too deep, it can be traumatic. Means the the lower incisor is occlude on the upper palatal mucosa. So in long term, they cause damage or impinging on the upper palatal mucosa. In long term, they strip the gum and it cause a lot of gum dissection. Then sometimes they are not only stripping the gum, but it can deep until the bone. So this is quite dangerous. So deep bite, a lot of time we try to correct it early before it causing any trauma to the palatal mucosa or the teeth. So reticulations are upper incisor, then sometimes stripping of the lower labial gingiva. So same thing, if the overlapping between the upper incisor is too much, the lower incisor will cause the stripping of the upper palatal gum, but the upper incisor will cause stripping on the labial surface of the lower incisor. So you get both upper and lower damage or trauma. So the lingual crossbite or scissor bite of the first, second molar, which is commonly found in class division 2, due to relative position of the width of the arches. So imagine if this upper incisor retrocline a little bit, then this in the premolar width is going to increase because everything will squeeze back. So if the incisor will bring backward, it means you have a whitening of the upper arch a little bit. So this premolar width is going to be increased. If the premolar width increase, cause scissor bite. So upper incisor retrocline will cause the whitening of the in the premolar width, which will cause a scissor bite. Just mean the scissor bite on the premolar area. So what's the treatment planning for class division 2? So we talked about the incisor angle just now, it should be about 134, 135. So this is considered the perfect angle. So perfect angle will cause a more stable result. So let's say if the angle is not correct, then the first thing we have to correct it to the perfect angle. So correction of the incisor relationship require a reduction of the increased overbite and the incisor angle to 125 to 135 for stability. So why we have to increase this incisor angle? Because the lower incisor edge has to bite on the synchronous petal, which is the middle third. So if they bite on this synchronous petal, then that's considered stable correction. So which is about 125 to 135. So this one is more than 135. So you have to reduce it or correct it to this angle, which is more stable. So this is not stable because the lower incisor can over-erupt and can bypass each other. It causes a deep bite again. So you have to correct this angle to 125 to 135, which is more stable because the lower incisor edge always rests on the upper incisor, which is a palatal 1/3. Okay, so how we're going to correct the class 2 division 2? It's not easy because the angle of the incisor is not correct. So the inside incisor can be reduced. So just now we talked about this. It's more than 135. Then we have to reduce it back to the 125 to 135. So how are we going to reduce it? So we have to do some talking. So talking of the incisor root. So talking means just talking, changing the angle of the root is called talking. So you're changing the angle of the incisor crown, you consider tipping. So tipping you can do simple removal. When it comes to root talking means you have to move the root bodily. Then this one is best to deal with the fixed braces. So talking of the incisor root palatally, it just means pushing the root backward, or palatally, or lingually. So this one usually you need the fixed metal braces to do it. So proclination of the lower labial segment, then proclination of the upper labial segment, and functional appliance to correct the resultant overjet. So sometimes if they are cluster division 1, it means the upper incisor, just the central incisor retrocline, but the lateral incisor procline. So how are we going to do it? We will convert this cluster division 2 to cluster division 1. It means we align the upper teeth, make the incisor stick out even further. Once you convert this cluster division 2 to cluster division 1, then after that, you can do the functional or twin block to bring the upper incisor back. So you convert this, make the overjet worse, and later you bring it back by functional braces later. So we can do a combination of both. I mean the porcine, the upper incisor and lower incisor. Then you bring it back, which is using the fixed braces. So you see this one is the retrocline, the upper incisor and lower incisor. Deep bite, maybe severe bite, traumatic bite. Then we porcine the upper incisor using the fixed braces by doing the root talking. I mean to bring the upper root and lower root more lingually or palatally, and then pushing the crown forward. This one consider root talking. And after you correcting the inter-incisor angle, then you can open the bite, then doing some rubber band to bring it back with the fixed braces. So reduction of the overbite. Let's say patient have a deep bite, how are you going to settle it? So a lot of time, if they have a deep overbite or severe overbite, then we have to do some intrusion. Maybe we have to separate the upper and lower incisor. So the first thing you can do is the true intrusion. So using the fixed appliance and headgear, but the risk of root resorption. So if you're using this fixed appliance plus a headgear, you see this one is a high pull headgear. Don't worry about this headgear. We're going to talk about this in another lecture series. Then this headgear, you see the high pull headgear means using the skull or occipital as an ankle, then attach a rubber band to the upper jaw. Then by doing that, you can do some intrusion. It means intrude the upper teeth or bring the upper teeth upward. Then by doing that, you're going to open the bite. But this headgear plus the fixed braces consider high force device. So when you apply the high force to the teeth or the root, there's always a risk of the root resorption. I mean the root will become a bit shorter. So increasing the anchor unit and use a bypass arch improve the true intrusion of the incisor. Bypass arch means the bypass. So you see this one have two wires. So this one I consider fixed braces. There are two wires. So this one got bypass arch. So this one usually have an intrusive force. You see there's a step between the incisor and the canine. So this is doing the intrusions or opening the bite. So it can be done. So of course, if you apply the high force device to the teeth, it causes a lot of root resorption. So the heavy force you apply to the teeth, then the shorter root you're going to get. So this one you have to be careful. So when the root becoming too short, they usually become a bit shaky. So you have to use the teeth until you're 80 years old. So let's say if you shorten the root too much with the braces, then the teeth might not survive for long. So relative intrusions, it just means using the anterior bite plane, then relieving the buccal occlusion, then allowing the lower molar to erupt. Then this only can be done in growing patients. Then the eruption of the molar and spontaneous proclination of the lower incisor when anterior bite plane. So imagine if you put this removable or anterior bite plane, so they separate the upper and lower teeth. So this bite plane, it means you have put something like acrylic or thickening of the plastic on the anterior teeth. So by doing that, then the lower incisor cannot bite on the upper incisor. It means the separation or open bite between the upper and lower molar. So if you leave it long enough, the upper and lower molar will be over-erupted. Then will come together again. So by doing that, then the bite will be opened up. So this one only can be done in the growing patient. Because adult, a lot of time, our teeth is not going to grow anymore. So over-eruption, a lot of time, that doesn't happen that fast. So growing patients maybe can do this. So erupting of the molar and spontaneous proclination of the lower incisor of the anterior bite plane. So this anterior bite plane, they not only separate the upper and lower incisor, they also cause proclinations. So imagine you have a block of plastic, just bite on the incisor edge, they will push the lower incisor forward a little bit. So they cause a proclination of the lower incisor with this anterior bite plane. So this picture also summarizes, you see over-eruption of the molar and proclination of the lower incisor. This can be done by removable braces or appliance. Extrusion. So just now I talked about the intrusion, then which is the incisor, and we talk about the extrusion. So only extrusion of the molar to correct the deep bite. So sometimes we can do combination of both, intrusion and extrusion. Intrusion of the incisor, extrusion of the molar. So advantages in reduced vertical skeletal proportion like Class 2 Division 2. So we know Class 2 Division 2 have to reduce lower face. So if you extrude the molar, it means we are going to increase the vertical height, which is going to help the patient's skeletal profile. So short lower face, then maybe we can do extrusion of the molar. But if the patient already have a high angle or long face, then maybe we are not going to do the extrusion of molar because you don't want to make the face longer. So short face, maybe we can make it longer. Then if it's a long face, maybe we have to be careful. So surgery, when it comes to severe case or not growing patients, adult, and severe case, deep bite, and a lot of time we have to do orthodontic surgery. So we can do impactions of the upper jaw and sometimes advancement of the lower jaw, or combination of both. So space for relieving crowding by extraction or distalizations. So if you need a lot of space, you want to bring the upper incisor backward, then most of the time we go for extractions, take out the premolar. Then we avoid the lingual movement of the lower incisor. Because like we say just now, if you bring the upper and lower teeth backward, you're going to make the overbite deeper, and you make the severe overbite worse. So if you're not doing fixed braces, you just do simple tipping, then you're going to make the overbite worse. So you want to reduce this overbite. A lot of time, class 2 division 2, we go for the fixed braces because you need a lot of good talking and changing the incisor angle. So especially if you take out the premolar, then it's a bit tricky to do it with the removable. So usually the fixed braces will be more suitable. And space closure is more difficult in reduced vertical skeletal proportion. So short face, let's say this short face with a reduced angle. So forward rotation, short face. Then this kind of patient, if you do extraction of premolar, it'll be more difficult for the space closure because the muscle is stronger. Then they usually lock the jaw together. They make the space closure a bit more difficult. So procrastination of the lower labial segment, caution to avoid gingival resection. So if you're going to procure the lower labial segment, you have to make sure you open the bite. If not, cause more gum recession because the upper teeth is biting on the lower gum. So functional appliance can be used in the class 2 skeletal pattern, relatively well-aligned lower arch. So if you're class 2 division 2, you want to do functional because they don't have this overjet. So first thing, like I said before, you need to convert this to the class 2 division 1 first. Class 2 division 2, you convert to class 2 division 1. Once they have this increased overjet, then you can do functional appliance to bring it back. Okay. So to summarize the lectures, so first thing I think for the class 2, division 1 or class 2 division 2, first you have to identify the ethology, whether they're skeletal, dental, soft tissue, or habit. Once you identify the ethology, then only you plan for your case. You do a treatment plan. So if skeletal problem and the growth is favorable, it's still growing, teenagers or young adult, then maybe you can do some growth modifications with functional appliance or even headgear or sometimes combination of both. So it depends on maxilla or mandible is a problem. So let's say maxilla is a problem, too problematic or too long maxilla, you can do the headgear, try to bring it back. If the mandible is too short, then you try to do functional to advance the mandible back, mandible forward. If the combination of both, upper maxilla too forward, mandible too backward, then you can do headgear plus functional, both together. So the mild case with the skeletal class 1 base, then can be treated with removable appliance. Let's say it's slightly procure upper incisor, we got some gap, then maybe you can use a simple removable with a labial bowl just to bring the upper incisor back. By doing that, the patient will change from potentially incompetent lips to competent lips. Then cases with a severe crowding or procrastinations require bodily movement, we always treat with the fixed appliance. So fixed appliance is about bodily movement, but if you come to simple tipping movement, you can do with removable. Or sometimes some severe cases, then you have to do with surgery. So when it comes to orthodontic only or braces only, you can do orthodontic camouflage. It means you use alternative in the absence of growth. So this one, it means the patient is not growing. You still can do orthodontic, but you're changing the incisor angle. So most of the time we do extraction of the premolar. Then by bringing the upper incisor back, then changing the angle of the incisor, then we can reduce the overjet. But the skeletal still remain class 2. This is called orthodontic camouflage. So severe skeletal or dental discrepancy in adult is managed surgically. So when it comes to severe, patient not growing, then the only choice by surgery. So braces cannot achieve the reasonable result, then you go for surgery. So occlusion must have a soft tissue harmony to avoid the relapse. So like we said before, the lower lip have to cover the upper incisor 1/3 to achieve the stability of the result. So let's say your lower lip cannot cover the upper incisor, then whatever you do, the correction might not be stable. So you have to be careful. Huh? So the lip or the soft tissue harmony is very important for the stability of the result. So retention phase until the growth is complete is very important. Let's say you start the patient too early, then you have to retain the patients until they stop growing. So you start early, it means the retention phase will be longer. But it's very important to retain the patient until they stop growing, because if it's still growing, there's a high chance the malocclusion will come back or relapse will come back. I think with that, I cover most of the lectures. Do you have any question to ask me? If not, I think we go back to this learning outcome. So you should explain to its classifications and ethology of class 2, division 1 and 2. So classification, we know both class 2, division 1 and class 2, division 2, both using the same classification. The first one is the British Standard Institute, which is classified the incisor. So whenever the incisor is biting behind the cingulate petal or the middle 1/3, it's considered class 2 malocclusion. Division 1, it just means the upper incisor slightly stick out or procline. Then division 2, it just means the upper incisor retrocline. But both lower incisor edge is occlude behind the middle 1/3 of the upper incisor. This must be very clear. No? Then we come to molar classification. This means the mesial buccal cups of the upper incisor, upper molars, mesial buccal of the upper molar, occlude anteriorly or mesially of the mesial buccal groove of the lower molar. There's an anchor classification. Discuss the criteria, the ethology of the class 2 division 1 and class 2 division 2. So it can be skeletal. So skeletal means the class 2 division, the class 2 skeletal, it means the upper maxilla can be forward, or it can be lower mandible backward, or it can be combination of both. Then we come to dental. That means the teeth are crooked. There's a causing the class division 2. Then we come to soft tissue. It can be the lip. The lip is causing problem. Too strong, or the lower lip is trapped behind the upper incisor, causing the upper incisor proclamations. Class division 2. This one also soft tissue. And the final one, the last one, can be heavy. So again, thumb sucking. So when you come to thumb sucking, what are you going to ask? You're going to ask how often they suck the thumb, then how hard they suck it, and then how long they suck it. So duration, intensity, all these have to know when you ask the patient. Then discuss the criteria for patient assessment. So when you assess the patient, same thing. You can do extraoral, then go to intraoral. Then necessary, then you take a mold top bottom, then radiograph, then before you come to the final treatment plan for the patient. So explain the clinical features in class 2 dip 1 and class 2 dip 2. So you can go for the extraoral features, which is skeletal. Then later you go to intraoral, then which is the teeth, dental features. So this one you talk about skeletal, then like we said before, upper maxilla is a bit too long, lower mandible is a bit too short, or combination of both. Then dental features, then you can talk about upper incisor, procline, retrocline. Then class division 2 usually have a deep bite. This I have to mention. So, treatment planning, then for the class 2 dip 1, a lot of time we try to reduce it. That means reduce the overjet, bringing the upper incisor back. If they are very simple proclination of the upper incisor, then maybe you can use the removal with the labial bowl just to bring it back a little bit, provided they have space. If the mild to moderate, then you can try functional, which is modification of the growth. Then if they're not growing patient, then a lot of time we either deal with the camouflage using the fixed braces, or the severe case, then a lot of time we have to deal with the surgery. So same with the class 2 division 2. So sub 2 division 2 a bit tricky, because usually this patient they have a severe deep bite. So you have to open up the bite first. So how you're going to open up the bite is by doing this simple removal with the anterior bite plane, then allow the over eruption of the molars or the upper and lower. But this only can be done on the growing patients. If they're non-growing patient, there are a lot of time you have to use the braces or sometimes even surgery for the severe case. Okay, I think by that I cover most of the lecture topic. Any question to ask me?
No question, Doctor.
No question.
Yeah, go ahead.
No question, Doctor.
No questions. Okay.
Excuse me, doctor.
Yeah.
I want to ask one question.
Yeah.
Just now you explained about the class 2 division 1 and 2, right? I just
Yeah.
wonder, actually this situation can be managed with the pallet expander or not?
Pallet expander. So, okay.
And then one device we do it in, with the acrylic at the middle there, then you're using a screw mechanic to expand it.
Okay, good question. So why you want to expand the upper arch? Why you want to expand?
From just now you explained about the division 1, there is because doesn't have enough space, is it? I mean, for a certain situation, they don't have enough space, so you have to do like orthodontic camouflage or.
We need the space for the retraction. You see, we want to retract the incisor back. You need the space behind the incisor. In order to pull the incisor back, you need the space at the back. That's the space you need. So if you need a lot of space, a lot of time you take out the premolars. You generate about 7 meters space, so you can pull the incisor back a lot. But expander is a different issue. So expander, you want to expand the arch because you have a narrow upper maxilla. Maybe you have to put an expander to widen the arch again. So this one only use it when you have a narrow maxilla. They only put the expander in. So for this class 2 division 1, let's say you have a thumb sucking habit and causing the constriction of the maxilla. Yeah, maybe you can put expander. But expander doesn't give you enough space for the retroclination of the upper incisor. A lot of time, let's say the incisor stick out about 10 millimeters. The expander is not going to generate the space for you to pull the incisor back for 10 millimeters. You need the extraction of the premolar in order to bring the incisor back. So I would say expander most of the time is for the alignment of the teeth. So I think this one, maybe we will talk about this expander in a different lecture series, not in this class of division 1 or division 2 topic. So remember, if you have narrow maxilla, only you put an expander because you want to widen the arch. So let's say for class 2 division 2, just now we already talked about this class 2 division 2, sometimes you have a scissor bite on the premolar area. So you already have the premolar area which is quite wide compared to the mandible. You already have scissor bite. So why you want to expand the upper jaw again? So don't confuse with the expander. Expander is a different device just because you want to widen the upper arch. That's why you use expander, not because the upper teeth stick up. Hope I answer your questions.
Okay, understood, doctor.
Do you have any other questions? No? No questions? If not, then maybe we'll end this lecture. So the next lecture, I think is same time next Wednesday, 2 p.m. We're going to talk about the class 3 skeletal pattern. Same thing, we're going to talk about ethology, clinical features, and how to treat. No questions? If no question, I think make sure you sign your attendance. Then I'll see you next week then.
Okay, Doctor. Thank you,
Okay.
Doctor.
Okay, thank you, doctor.